Hi there, and good day. My name is Dr. Bunye Emmanuel Mbamalu, and today we're going to be going through how to answer a standard USMLE style question. So I'll go ahead and start sharing my screen. And this is the question we're going to be focused on. Whenever you see a USMLE style question, more often than times than not, you want to focus on the prompt at the end. Here it says, which of the following profiles most accurately represents this patient's current physiological state? And then you want to evaluate the option choices you have. After you've answered enough questions, you start getting an appreciation of what the question is asking. In this case, these are varieties of parameters that describes different types of shocks. So what we want to do is we want to highlight the aspects of the stem that then can help us differentiate between the types of shocks. So this is a male, 68, that's had an MI 3 days ago. So we're just trying to think what kind of shocks could be complications of MI. Here's an altered mental status with cold extremities and shortness of breath. Cold extremities, that's usually in either neurogenic, hypovolemic, or cardiogenic shock. On physical examination, the patient is in respiratory distress using accessory muscles, diaphoretic with jugular venous distension. So an elevated JVD tells us that blood is being backed up. It's unable to go all the way through our hearts to get into our arteries. So from elevated JVP, we can tell that at the very least, blood isn't able to get past the right atrium. Pulmonary auscultation reveals bilateral crackles. So now this tells us that the blood is not able to get into the left atrium. If we have a picture somewhere where we can look at the anatomy of the heart, we can have a good visual to draw on. Okay, so over here, we can see that the pulmonary trunk leads into the pulmonary arteries, which eventually should feel into the lungs, and then finally back into the left atrium. If we're having issues with our lungs, it means that we can expect a low pressure in the left atrium and reduced cardiac output, which seems to be what we're having here. And that's often the case if we have a dysfunction in the left side of the heart, which is usually synonymous with a cardiogenic shock. We see S1 and S2 are present and faint, with an S4 gallop presence as well, which is not unusual in a myocardial infarction. No other mummers, and we have an extended capillary refill of 4 seconds, which is telling us that we're having some issues, hemodynamic compromise. Temperature is normal. That helps us rule out septic shock. This further adds to a diagnosis of shock, as well as heart rates, tachycardia as well, hypotension, tachycardia, tachypnea, and oxygen saturation, that's 86%, even though the patient is on oxygen. This ties in very well with the pulmonary congestion, right, with reduced diffusion of oxygen because of likely the blood that isn't able to get into the left side of the heart and then into the arteries. So we've done invasive hemodynamic monitoring via pulmonary artery catheter, which gives us a PCW. PCW is often a very confusing concept, but it's one of the best ways to diagnose different types of shock. Whenever you see PCW, the best way to think about it is as the pressure in the lungs and in the left atrium. So if PCW is elevated, that is basically telling us that there is some form of increased pressure in our lungs, which would happen in cases of congestion, or increased pressure in our left atrium, which could occur if the heart isn't able to effectively pump blood out into the left ventricle and into systemic circulation. So it's just basically telling us the pressure in our pulmonary arteries, our lungs, and eventually our left atrium. In a case where we have a failure of the left ventricle, we can expect the PCW to be elevated, which we have in option choices B and E. We expect cardiac outputs to be low, which we also have in options B and E. We'll expect the body to try to compensate by vasoconstricting to make up for the low cardiac outputs, which we do see in B. We don't see that in E, which is marked down. And central venous pressure should be elevated. That connects to jugular venous distension, which we do see in B and E. So the differentiating point is our systemic vascular resistance. That's just normal hemostatic response to a low blood pressure if our nerves and our sympathetic system is intact. And we also don't have any bacteria causing a cytokine chemokine storm, forcing vasodilation as we would in septic shock, which we're able to rule out. The other options, as we have over here, when we have low CVP, low cardiac output, low PCW, and elevated SVR, is classic for hypovolemic shock. That's the case because we can see there's low cardiac output. That means the left-sided heart isn't quite working as it should. Low PCW, which means low pressure in the lungs and the left atrium. Elevated SVR, the blood vessels trying to compensate. Low CVP, which means there's low blood on the right side of the heart. So the only case where we're going to have low blood both on the arterial and venous side is if we have low blood generally. That's hypovolemic. This we've already said is cardiogenic. With option choice C, we have elevated cardiac output. That only really happens in septic shock. But let's see if the rest of the values support that finding. Reduced PCW, that's lower pressure again in the lungs and the left atrium. Reduced SVR, that's the body not able to compensate by vasoconstricting, which does happen in septic shock and neurogenic shock, as we mentioned before, and low CVP as well. This is because of generalized vasodilation. So this is classic for septic shock. With D, we have reduced cardiac output, reduced PCW. So left side is not working quite as well as it should. That's what these both tell us. There isn't any congestion in the left atrium or the lungs really. Increased systemic vascular resistance. Our blood vessels are functioning well, and increased central venous pressure. So increased central venous pressure means we're probably going to have jugular venous distension. So there isn't congestion in the lungs or the left atrium, but there is congestion on the right side of the heart. This is a picture of obstructive shock, usually because of a pulmonary embolism. That's or perhaps constrictive pericarditis. Then E, we have reduced cardiac output, increased PCW, reduced SVR, increased SVP, very similar to our B. The only difference is that the body isn't able to compensate through vasoconstriction. So that's a lack of a neurohumoral response. For some reason, the adrenergic receptors alpha-1 is not responsive. This is classic for neurogenic shock. And there we have it. How to break down USMLE style questions for the most part. Focus on the prompts. Assess and analyze the questions. Try to discuss the option choices you have available, because oftentimes each option choice does represent a specific diagnosis of disease. The better you know all of the diagnosis, the more likely you are to actually get the right answer. But even if you can't, you can at least have a 50-50 and rule out unlikely option choices. All right, that'll be all. And thank you.